This week on the Back Table Podcast.
There's a lot of motion in the lung, which kind of throws it out the window, a lot of artifact, and it's kind of a terrible thing to say because in the end of the day, we're medical scientists, but I do feel there is a bit of an art to the ablation. There's a little bit of knowledge that is gained from experience to knowing that you've treated the entirety of a target lesion. I would say in thoroughly evaluating Rob's work, he's usually correct, and I think that I am too, but sometimes we are incorrect. I'm actually envious of only one thing that Alan provides, which is these colorful, rings of radiation, maybe other things, but to know specifically what we're delivering into the lung to achieve efficacy and to prevent adverse events.
Well, welcome to the last session of Lung Creator Weekend for primary lung cancer. Let's do a quick round of introductions again. And Scott, why don't you start?
Scott Genshaft, UCLA Interventional Radiology.
Scott O from USC Interventional Pulmonology.
Rob Su, UCLA Health Thoracic Interventional Radiology.
Alan Lee, Radiation Oncology at UCLA.
And Kavi Krishnasamy, Interventional Radiologist at UAB. Welcome, everybody. Finally, last session of the day, and we'll let everybody go and hopefully enjoy the evening. But let's start with a little bit more on ablation. I feel like of all the things we've covered today, we haven't really talked a lot about ablation of all things. So let's talk a little bit about ablation. Rob, you went into kind of some of the details about the different ablation modalities. Obviously, the three of us use a lot of ablation, and both of you are familiar with ablation. One of the things that I struggle with is ablation zone sizes in the lung and what are we using for confirmation in the lung, right? There's a lot of literature now for confirmation in the liver, but we haven't really adapted some of those things to the lung. So what are you both using for confirmation in the lung post-ablation? Or how are you evaluating your ablation zone in real time?
Well, I think one of the biggest questions that came up in a survey to operators across the world, this was probably a decade ago, I think the biggest number one thing that we all wanted as interventional oncologists who do ablation was to have confirmation of, did we actually do what we set out to do? Did we kill the tumor? Did we cover the tumor, right? And obviously, ablation confirmation is an attempt to at least give you some idea of what you covered. Now, in the lung, it's a little bit, maybe it's a little different in the liver, but to some degree, we've relied on sort of the imaging surrogates, particularly what has been known as the ground glass attenuation that follows RF ablation, but also microwave ablation. And with cryoablation, it's kind of a more built-in, not just ground glass, but it's consolidation, and you can kind of see the ice, so you kind of know what coverage areas you have. It's interesting because we do play around, or we have ablation confirmation at UCLA, and we use it in the lung, but oftentimes I think at this point, for me, and I don't know about you, Scott, is that when they run it, I'm happy when it agrees with what I think. Yeah, because as maybe a more experienced operator, I kind of have a feel for what we're doing anyways.
Sure.
But I don't know, Scott, do you have
I don't use ablation confirmation software. I find it tedious. There's a lot of motion in the lung, which kind of throws it out the window. A lot of artifact, and it's kind of a terrible thing to say because in the end of the day, we're medical scientists, but I do feel there is a bit of an art to the ablation. There's a little bit of knowledge that is gained from experience to knowing that you've treated the entirety of a target lesion. I would say in thoroughly evaluating Rob's work, he's usually correct, and I think that I am too, but sometimes we are incorrect. I'm actually envious of only one thing that Alan provides, which is these colorful, rings of radiation, maybe other things, but to know specifically what we're delivering into the lung to achieve efficacy and to prevent adverse events. I don't know how we're going to achieve that. Perhaps you have some ideas, but I think it's going to be quite difficult.
Yeah, I think some of the difficulty kind of arises that even if we can trace what are the edges of the ablation zone, we don't really know what the dosimetry throughout that ablation zone is, right? Now, some people use temperature as maybe a surrogate. Some people put additional thermocouples in at the edge of maybe a concerning margin to get an idea, did their ablation zone extend to that extent? But largely, we don't really have a lot of feedback in our, for instance, our microwave antennas to have some other ideas of what's going on. But I think this has to continue to be developed, because what we're trying to do is, right now there's X amount, like a small group of people doing lung ablation in the world, right? And especially in the United States. But how do we get kind of the less experienced person to a certain level of confidence?
And just democratize the intervention, right?
Exactly.
Yeah,
and so that's where we have to get to. And that's what these sort of software tools, however good they may be, and hopefully in the future they will be very good to kind of get up to that level. So the other thing is familiarity with a device, right? So again, last year we published a nice paper where we came up with mathematical formulas and then validated them on predicting the long and short axis of microwave antenna ablation zone. And so this is only measuring the ground glass, but at least now we have some real human data kind of looking at what is that size we're creating. And so when somebody goes into a procedure using this device, they at least have an idea of what they can expect. Because I think for the most part, except for one manufacturer, nobody has a true in vivo ablation predicting chart, time power chart in the lung, right? So you're just doing ex vivo tissue, which is a little bit meaningless.
Yeah. And only one manufacturer now has thermocouples built in at the 3, 4, 5 centimeter mark. Whether that will correlate with the ablation zone in the lung, I don't think we know yet, but that'll be interesting to see as well. So there are absolutely challenges there. How long do you wait for microwave for that ground glass to develop?
Well, the long and the short of it is wait as long as you need to wait. So I typically say, look, if you scan that area or after you finish the burn, take a slow walk back. You can wait 5-7 minutes, typically is what I start with. But I wait till I feel comfortable enough to say, okay, well, I think I did what I did. Now, the problem is, as you can imagine, is that the ground glass, first of all, underestimates.
Sure.
And even when you start seeing it, still may underestimate what you did. And so that's why having something predictive or adds value. So you know that, okay, I put in this amount of work into the space, so, I should expect this. And so then maybe even as the ground glass is just appearing, you go, okay, that looks about right.
Yeah.
Otherwise, if you're not confident, the worst thing you can do is start putting more energy into an area that's been pretty well treated, but you just didn't think so.
Yep. Good.
Yeah, I'm not very patient. So
I don't think many IRs are patient. So yeah. That is a common IR sentiment. So yeah.
One of the beauties of microwave is that you can get in and get out, particularly for larger lesions. And I often, if I've delivered enough energy, won't wait. But there are certainly cases in which I think it's vital that you wait for the ground glass to set in, not to know precisely what your margin is or what the ablation zone that you've created, but to get a sense of how much energy you've deposited. And one thing that I've found very useful recently over the past couple of years is that my CT scanner will automatically segment the area that I'm working into multiple planes. And so looking at the ablation zone, not just in that axial plane that you've probably predominantly used for placement, but looking at a sagittal and coronal will much better give you a sense of what that ablation zone is. And I highly recommend it when you're kind of in that waiting phase.
Yeah, for sure. I think doing reformats is a must because sometimes that ground glass is just easier to see for whatever reason. And so, yeah, definitely do that.
Yeah, that's a great point. I'll still confess on the cryo side, I don't always get that consolidation or alveolar hemorrhage around the lesion to then be able to freeze. So sometimes I'm just, for slightly larger lesions, I'm just looking visibly like, does the lesion look frozen? But then what is the isotherm that I'm getting? And that's the challenge. It is not as predictive as some of the other organs that we have, software that kind of works well. So that is a gap. Hopefully we will continue to address it. How are you choosing modality?
For me, it's kind of location of the lesion. So just as a rule of thumb, if you have something that's out in the subpleural lung or peripheral lung that the ablation zone is going to involve the parietal pleura or chest wall intercostal nerve, I'm always using cryo, because you also can move the lesion by sticking it and kind of moving it further into the chest, and it's just kind of easy way. I don't often create artificial pneumothoraces and stuff because it's so easy in most cases to move the lesion away from the chest wall. For kind of more parenchymal lesions or just things that are more in the middle of the lobe, then microwave is probably the go-to in most cases. And then for central lesions, it really kind of depends again where it is and how much do you need to see that ablation zone and control it, right? So ice is going to be easier against a backdrop of soft tissue than trying to put in heat energy.
Yeah, I think that's a great point. What about you, Scott?
Yeah, I agree. I have a similar framework for choosing my modality. A lot of this is determined based on the type of sedation that I utilize,
That's a
which
good
is
point, too.
only moderate sedation.
You don't
or
use any
local.
general anesthesia?
I use zero general anesthesia.
Wow. Okay.
Zero. And so, and it's because I like to be in control. So not only am I impatient, but I like to be in control of the situation. And I feel like I am when I'm using moderate sedation. And I find it super essential. In many cases, for example, patient has a central lesion that's near the phrenic nerve or near the recurrent laryngeal nerve. I'm talking to the patient to see if they're having any issues. I'm high up in the apex. I've decided, I'm going to go a little more aggressive and not send the patient to Allen for radiation. I need to do some exams on the patient's hands to make sure I'm not hitting the brachial plexus. I want to do that with them awake. And so when one performs a cryoablation to an area that abuts a sensory nerve, it's almost painless. With microwave, it's variable discomfort. A lot of times with tumescent anesthesia, dating back to the days when we used RFA under moderate sedation, some tumescent anesthesia and nerve blocks, you can also achieve relative patient comfort. But yeah.
Yeah, I think the most users out there, I mean, it's very interesting because there was a survey in 2004 of the lung ablation people kind of in the world. And at that time, probably 70% of the operators used conscious sedation and the rest using general anesthesia. But since that time, it sort of flipped. And in the Eclipse and Solstice trials, probably 2/3 or slightly higher than 2/3 were being done under general anesthesia, and the minority, about 30%, a third being done under conscious sedation. So I think the landscape has changed for many different reasons. Again, I'm like Scott. I like conscious sedation because I think the breath or the lung volumes you can achieve with the simple small breath hold when a patient is awake is far better than when I have my anesthesiologist do it. The worst thing you can do is when the lung is underinflated and you can't see the lesion because of atelectasis, or as the case goes on, the lung volume starts shrinking and then you really can't cut the lung very effectively and everything is crowded. And we didn't really touch upon this, but with microwave energy especially, there are regional differences in how you create or the size of the ablation zone that's created. And when people think about microwave, or even RF, they think about heat sink, which is perfectly appropriate, but they think of heat sink in the setting of just a large vessel or a large airway. But I would argue that heat sink is really more of a product of the regional ventilation perfusion. And so that means that if you have or use a certain time and power, that will create a bigger ablation zone in, for example, a upper lung periphery than it will in the lower lung central portions. It'll be smaller because there's more ventilation and perfusion. And this is kind of why endoscopic or endobronchial microwave is difficult, because you're plugging that airway up and you're also ablating. Well, right next to that bronchus is going to be an artery. And so when you're plug that bronchus up, you're going to decrease the ventilation. That's going to alter what you expect. Then if you knock out the artery while you're doing that, well, now you've got an underventilated, underperfused area, which is going to be, it'll be sometimes catastrophic in the sense that your ablation zone can be significantly magnified, right?
There's another clinical context that we can see this magnification of particularly microwave ablation zones, and that's in patients who have had radiation in that area, probably because there's destruction of the vascular bed or at least some damage, so there's regional differences in perfusion. And so very large ablation zones can be achieved, which is great for the destruction of tumor, but it's sometimes a little bit much.
Yeah, as long as you can predict it, but we don't have any model that does it. And other situations where the lung ventilation and perfusion is altered are not just, certainly in radiation fibrosis, but also interstitial lung disease, emphysema, right? Cases where even when somebody has had a previous surgery or even ablation, then you've altered, in some case, the ventilation perfusion in the remaining lung.
Yeah. Great point. It makes me feel like the antiquated one. I still use a decent amount of general anesthesia, I will say. I also actually have a fairly low threshold. I emulate that algorithm almost exactly. I tend to use cryo peripherally and centrally, and microwave kind of in the middle of the lung. I do feel like I have a relatively low threshold to just drop the lung if I have to, and I do it fairly frequently. But then your point about atelectasis is very important, I think, for maybe the less experienced interventional radiologist. You put a patient to sleep and you leave a small lesion in the, you leave the patient supine and the lesion is posterior, you will absolutely lose that lesion, right? And if you add PEEP and you do recruitment maneuvers, then you're also increasing risk of pneumothoraces and all of those things, right? So positioning, I think, is very important. How you target that lesion, what we talk about, a ablation approach and a biopsy approach and more of a tangential approach as opposed to coming in perpendicular to the pleura as those ablation zones grow back along the probe into the pleura and the subcutaneous soft tissues is also very, very relevant.
One additional mechanism that I think is essential for targeting is to think of the lesion and the human as not having been created in the axial plane that we're used to viewing 100%. CTs.
Yeah.
So again, the CT scanner that I perform my ablations on automatically segments needle trajectories and allows for correction. So it is actually rare that I use the axial plane. I am more commonly using a sagittal plane, which is much more anatomic for most patients in approaching the lungs. And it allows one to attack a nodule, destroy it, that previously would have been impossible with ease. So I highly advise that.
I echo that, and I rarely work in the axial plane, actually. I don't actually angle my gantry very commonly. I just feel like it kind of impedes my freedom of motion, but I very commonly work out of the axial plane and target lesions in different planes, and just it's something that I think comes with time and a little bit of experience. So great point.
How do you create artificial pneumothorax?
Great point. There's a series of needles that are kind of blunt tipped, get through the pleura, or actually they cut, you get through the pleura and then the blunt tip bounces out and you can kind of infuse air that way. I also am patient, so I will just take an 18 Chiba and usually just drop it under CT fluoro into that kind of pleural space, inject a little bit of air, just make sure I know where I think I am, then drop a tube and then just drop the lung. And quite frankly, depending on the position of the patient, it's not just hydrothorax, pneumothorax. It's hydropneumothorax that is relevant as well. And so, if I have a patient in a decubitus position and the lesion is on the mediastinum, you can put 500 cc's of fluid and it will lift the lung up, and then you will moving away from the phrenic nerve like we talked about in the last session. So that's what I tend to do. What do you tend to do, both of you?
I tend to use a Varus needle, which is a blunt tip, spring-loaded needle. There's one that has a hole at the end.
Yes.
You can actually put an 035 wire through that hole and then put a chest tube in and then just modulate the air. I'd be interested how you actually drop the lung during a pleuroscopy.
Yeah, two situations. One, if there's fluid, then we don't need to drop the lung, right?
Great point.
If it's a dry space, we use a Varus needle, or we just use Callies and dissect down and pop through with the Callies and open them up and introduce the air that way, depending on what we're going to be doing.
Patients asleep or not asleep?
Under moderate sedation.
Man, I'm so antiquated. I need to change my approach, so.
Well, I think from Alan, you have a lot of spacers, like gels and stuff that I think we, as interventional radiologists, maybe we should come to you for more of these things so we can just put those into some of the spaces that we want too.
But they're expensive,
Yeah.
I think, right? Like space ore, things like that.
Yeah, I mean, for the indication that they're used for, they have different price tags, right? Because there are different clearances for what they're used for. You can use them off-label for a lot of things. But I actually had a question. So you guys mentioned using moderate sedation or general, and then introducing pneumothoraxes. So in composite, how many of your treatment-related or implant-related side effects result in a patient having to stay like overnight, let's say, for instance, in the hospital?
I don't know if I have the exact numbers. Rob may, but it's less than 5%. It's so much so that my patients, I'm almost exclusively performing my ablations in outpatient centers because I expect them to be going home.
Okay. And then in what sort of local control do you tell the patient or other oncologists when they ask?
It depends on what we're treating. So primarily when I'm treating non-small cell lung cancer, most of the lesions I'm treating, most of the cancers I'm treating are less than 1 centimeter in size. A lot of them are purely ground glass or part solid nodules. It's rare that I'm treating something that's above 2 centimeters. That's typically in patients, even though that our control is excellent up to 3, but it's those patients I'm often sending over to you to see. We expect control at 2 years, 3 years, 5 years of greater than 90% for lesions that are less than 1 centimeter.
So just to answer your question from more of a maybe an academic perspective, I think it does depend on what you're treating and the size particularly and even location. But there was a meta-analysis by in academic radiology, I think within the last 2 years, and they looked at a pretty good number of studies, and they found that the pooled local control rate was like 87%. And that was like, I think 3 centimeters or 2.5 centimeters and smaller. So that's kind of like what we're seeing in most papers historically. But of course, everybody does better with smaller lesions, right? So,
Great point. So size cutoff, do you both have a size cutoff?
it kind of depends on where the thing is, right? But ideally, I generally like things that are smaller than 2.5 centimeters.
I will go after slightly larger lesions, but I will give the caveat that I don't think the control is as good. And usually that's in a situation, multidisciplinary, and just that the whole team felt that this was the appropriate approach for whatever reason it may have been. Go ahead.
Yeah, the non-operative candidates, solitary lung cancer, it's over 2 centimeters. I'm usually sending it to radiation oncology. I fully believe that we can achieve local control in most of these patients. It's just location dependent, but I have much higher confidence that you can achieve appropriate local control. And so that's what I do.
And I think, having been able to collaborate with our brachytherapy team at UCLA, like a lot of times when I see something 3 centimeters, 2.8 centimeters, I don't even really talk about ablation. I go, let's just, I send, a text to Albert or
Sure.
Alan to, hey, let's do high dose rate brachytherapy on these cases. Yeah.
So that gets me to my next point. I do want to touch specifically on brachytherapy, but central lesions. I know you kind of briefly talked about central lesions. For me, I think in my practice, central lesions that are really encompassed by the kind of the hilar structures, that's the phone call I make. I send to my radiation oncologist invariably. And I just don't know that I feel confident that I'm going to get a true margin in that situation without destroying something. And so that is an easy call. And I do that fairly frequently. What do you do?
Yeah, if it's truly in the hilum. But there are areas near the hilum that I think are attainable, small nodule just above the hilum, just below the hilum, that I'll go after. But if it's really enmeshed within the hilum, I think there's a better way. And I think a lot of times it may not only be external beam radiation, there may be a role for brachytherapy that's introduced bronchoscopically.
So let's talk about brachytherapy, because your practice collectively, minus Scotto, nothing against Scotto.
No, Scott.
No, he does it too.
Oh, yeah, that's right. Oh, my gosh. That's right. Good point. Good point.
The original.
He was the OG. He was the OG. I apologize.
OG.
But you have a high-dose brachytherapy practice that is, I don't know, are there other centers in the U.S. that offer this?
So from my understanding, I think MD Anderson just created one within the last few years based on our sort of precedent.
Yeah, I think USC could probably do it. I don't know if Cedars is doing it, but they've done it before. Basically, anyone that's trained at UCLA has the experience in doing it.
I love it.
The problem is finding interventional radiologists to collaborate with, right?
Sure.
Because it requires a lot of extra time. There's a lot of extra learning involved. It doesn't necessarily change the reimbursement patterns or anything like that. So it can be difficult to get people to buy in sometimes.
So what is high-dose brachytherapy? What is the workflow around high-dose brachytherapy, and how are the different teams involved?
Yeah, so high-dose brachytherapy is essentially a radioactive isotope. It's usually at radium-192. It's loaded into a shielded container that's robotically pushed on a wire into a catheter that's placed into a tumor. The drop-off is very sharp, meaning that about so like about 1 centimeter away from the seed, it's very low dose, like an ineffective dose. Really, we try to keep it more like 7 millimeters around the catheter if we can. So if you're trying to treat something that's 1.5 centimeters from the needle tip or from the side of the seed, you probably have to put another catheter in, or you can just leave the seed in there for a lot longer.
There's a time dependency.
Right, yeah. And that's fine in most circumstances, right? I mean, if it takes 45 minutes, it takes 45 minutes because the center of the tumor is getting hot, which we don't really care that much about. Sometimes it'll get necrotic in the middle, but it is what it is as long as we're achieving local control. It's when the target is slightly off of the needle tip or the needle itself. Let's say it's like the tumor is 1.5 centimeters away from the catheter, then you just can't get enough dose to the tumor to cover it, which is obviously a huge problem. And so when we first started doing it, I was a fellow actually, and then as an attending, it does require some art, right? Like you have to have some experience in doing it where you look at it and you say, well, this is close enough or not close enough, right? Rob and Scott are trying to snake it under a rib or something, or between two structures. It can get tricky.
Sure.
But essentially it's a radioactive isotope being placed into a needle, and the needle is placed into the target. The seed goes into the needle and then deposits radiation in a cloud. You can make the seed stop along the needle. So you can make a bunch of snowmen essentially along that, or a caterpillar, and make the dose more of a hot dog shape as opposed to just being a circular shape or a spherical shape. Yeah.
And so to both of you, describe this catheter. What are you placing into the tumor? And I guess you can place multiple as well, obviously, right?
Kind of in the old days, when we started this, we relied on the brachytherapy catheter needles from the radiation oncology department, which were these sort of very heavy, re-sterilized or sterilizable things with a 5 French plastic sheath or catheter over it, but they were close-ended because once you put the seed in, you don't want it to be open-ended because then it'll contaminate the seed that can be used again, right? So, but they were really heavy, and so we had a hard time because it's a plastic tip, so it's tearing up the lung, so we're getting bleeding along the way. It's heavy, so it's falling over and then kind of torquing the lung and then opening that pleural space. So in many of those, in almost probably almost all of those cases, I remember you were as a fellow, right? So we would just get a pneumothorax, or you just go, okay, well, we put this in, and sure enough, we're putting a chest tube in at the same time, right? Because it's got to stay in for the next few hours, right? But since that time when Albert Chang came from UC San Francisco, I remember pretty vividly our first meeting, and so he brought all of the catheters that they had in their kind of cabinet, and I brought a bunch of needles. And so we settled on a 17-gauge introducer needle through which we put a 4 French brachytherapy catheter in. Yeah, so what we do is, so now it's just become, it's pretty straightforward because we're just putting in a 17-gauge introducer needle, much like we would do for a biopsy. Easy to steer, it's very light, there's no falling over, and we can get to pretty much anywhere in the chest. And then once we get that place, we just thread the 4 French catheter in, and then we actually have now a system where we can lure lock the catheter in place.
The Flexi Guide, the longer plastic ones. Another problem we had is that when we started using those, they would slide in and out of the patient, right? So the coaxial introducer needle has the Y clamp, right? And that holds it down to the patient. So we tape it down to the patient and keep it stabilized there. The Lurolock internal 4 French catheter we use was actually a design by one of our therapists who who retired a couple of years ago. So he submitted it to BEST, which is the company that makes the catheters for us. and submitted it and gave them the schematic and everything. And they designed us a custom Leerlock catheter that we use now. We used to tape it. Remember? We used to tape it, steri-strip it down, and it was just like this whole contraption. And then we had to adjust anything. We had to take off all the steri-strips. It was a huge pain. But yeah, the Leerlocks changed a lot for us. And then we have different sizes. We have like 3 different sizes depending on what length the tumor is going into. And then after the patient gets hooked up, the needle's placed, the patient then comes to our department. So they have to get hover matted over from the CT table to the gurney. The gurney is then transported from the CT room through the series of hallways and then down to our department where it's hooked up to our afterloader and treated. And then we have the patient come back up to the CT suite so that we can pull the needle out and then check for a pneumothorax. So the logistics are a bit more complicated than ablation.
Now, they have a scanner in their department that we could use, but often it's doing planning and other things.
Yeah.
And so ideally, if we could do it in the department, it would be easier.
Yeah, sure.
Yeah.
But it sounds like it's still filling a therapeutic gap.
Yeah, of
And
course.
these are patients,
Yeah, for sure.
right? And so there's value to the service line. Yes, there are workflow complexities, obviously, but there's value. What about the data?
So there are a few published papers, not necessarily all from our center, but the paper that we published, I think it was in 2021, we had 25 patients with 37 lesions, and we treated central lesions. So these were within 1 to 2 centimeters from a central structure, or ultracentral lesions that were abutting critical structure, right? So our local control rate at 2 years was 96%.
Wow.
So quite good,
Yes.
in fact.
Especially for the location of the lesion, right?
For the lesion.
Yeah.
And, as you can imagine, our complications were, mostly pneumothoraces. I think about a third of our patients had some pneumothorax, which is pretty good considering how long you leave that needle in, which is actually maybe a couple hours when it's all said and done. The other thing is we put in about 10 chest tubes, but most of those were just kind of transient, and we had no grade 3 or higher adverse events. Since that time, we've been kind of refining the process, and so now, when that patient comes back, I routinely put a BioSentry plug in, right? And then once I'm comfortable that the hole is sealed, then I'll just aspirate the pneumothorax and send them home.
Sure.
Yeah.
And that's what I do for all biopsies. We don't have a brachytherapy program, but I use a lot of BioSentry plugs. And then correspondingly, I think my pneumothorax rate is, again, less than 5%, kind of like you said. So good in those patients. So then knowing that service, and you guys have really pioneered that. And Scott, I still consider you the part of the OG crowd. So
we have a whole nother chapter probably on
the endobronchial
bronchial brachytherapy.
Wow. Okay.
Yeah.
All right.
So that's a similarly complicated process.
Okay.
But what we do is we bring our bronchoscopy cart into the brachytherapy suite. So we roll it all over from our procedure suite into the brachytherapy suite. Then we place the brachytherapy catheter through the bronchoscope, and then kind of a Seldinger technique where we leave the catheter in but take the bronchoscope out and then tape it really well.
And you can place multiple catheters or single catheter? Okay.
We can place multiple catheters. This is obviously easiest for directly endobronchial lesions inside the airways.
Okay, got it.
But we have done some where we create a pilot hole with a needle and then push the catheter through that pilot hole into peribronchial lesions as well. Yeah, but not a large volume of experience with that. Only a handful, more kind of feasibility data than real outcome data.
And mostly that's used for palliative purposes, to be clear.
Okay.
Yeah, because we have such good techniques to treat, external beam, we have ablations, we have surgery, right? So a lot of the times these are patients with, let's say they have lots of lesions, and one of them is obstructing and causing a lot of bleeding, and they've already had radiation there before.
Sure.
They're not a good candidate for anything, and so it's even less use cases, But we have done it multiple times in patients and had really good outcomes, surprisingly good outcomes for those patients that otherwise maybe wouldn't have any other options. Yeah, so that's another brachytherapy. Essentially, if anyone can place a catheter somewhere, we can hook it up to a afterloader and put a seed in there.
So it begs the question for central lesions, lesions that are within the hilum.
Yeah.
How do you decide how to do a brachytherapy versus SBRT?
Yeah, so typically I would prefer to do radiation, external beam. Okay. Essentially, a lot of our dose constraints are extrapolated. And when I say extrapolated, I mean they're kind of made up, right? Because
from old literature.
Sure. But usually it's not even that the patients had a toxicity, right? It's just that, well, we don't want them to have a toxicity, right? Because fatal hemorrhage is a toxicity that you can't ever have, right? So we're very conservative with things that are causing, super high grade toxicities, understandably so. So for the central structures, we try to keep the doses low to the important structures. But sometimes, even if we have to overdose it, we'll do so with the understanding that it's probably not going to be a problem anyway, because we don't actually know what the actual constraint is to this structure with this modality. And so with brachytherapy, usually we can get away with sculpting the dose right off of an airway or right off of a vascular structure that would prevent us from violating the constraint. So typically it's pretty safe. If the target is large, let's say it's large and the original patient you sort of presented was looking at a target that's wrapped around hilar structures, which in that case, it would be very difficult to get the dose to all the different parts of that tumor.
And just the cannula is there probably, right? So,
right, and so we would usually just use external beam. Okay. The closer you get to the mediastinum and important structures, the more fractions I would use, right? Because the structures are usually less sensitive to smaller doses spread over a longer period, the more fractions. So I'll usually do 15 fractions for tumors near sensitive structures. We also have a device, we have an MRI guided linear accelerator. Essentially most linear accelerators are CT based, right? So you do a CT scan, you do the treatment. Do a CT scan, you do a treatment. The MRI linear accelerator actually has a real-time sagittal plane imaging system that images in real time as the radiation is being delivered. Okay. So you can actually see the target moving or not moving, right? If they're breathing or not breathing. And then one of the software versions we have is that the patients can actually look at some goggles and they can actually control their own breathing. So they take a breath and then the little green square moves into the target and they hold it there. And as soon as they let go and it leaves that target area, the machine shuts off until they can get another breath and go back into that space. That machine sounds amazing, and it is amazing, but the planning that software and the planning ability of that device is not as good as the planning software for the other linear accelerators. So there is still some limitations. Or if they have hearing aids and they can't hear, they have to follow instructions. Or if they have a pacemaker that can't be turned off, or it's not MRI compatible, or if they have like shrapnel in their body from something, right? So, or if they're just too demented and they can't follow instructions or something, then so there's a lot of limitations to that device as well. But it's another very interesting and cool technology that we can use.
I'm just happy to hear that you too are a fan of patient-controlled breathing, unlike Covey.
Sounds like I need a change. Yeah. So, Great points.
Thank you so much for joining us on Backtable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _backtable onc. That's _backtable ONC on Instagram, X, Blue Sky, YouTube, or LinkedIn.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
Josh Spencer,
and Jaden White.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
See you next time.